Good afternoon, everyone. My name is Lisa Nagel from the CAP Center here at NDSU School of Pharmacy. Thank you for joining us today. It's noon, so we're going to go ahead and get started. We are pleased to welcome you to our next series webinar in chronic disease with today's focus on continuous glucose monitoring. The webinar today is called Hybrid Theory, Continuous Glucose Monitoring, Interpretation, Planning, and Documentation. We have a few housekeeping items for today. If you have questions during the webinar, please use the Q&A function. We will answer these at the end. During the webinar, Dr. Rue may ask a few questions, and you can add your information to the chat function as well. We will record this webinar for those who are unable to attend today, and this will be available on our website for the CAP Center as well as our YouTube page. And after it's over, I will send that out to all attendees. Please feel free to share this with your colleagues as well, because I know not everybody is able to jump on right at noon. We will also provide the CE information at the end of the webinar today. I'd now like to introduce our expert speaker. Jesse Rue, PharmD and BCPS, is a native of Hillsborough, North Dakota. He graduated from North Dakota State University in 2009. Dr. Rue served for 8 years as the pharmacy manager at CHI St. Alexis Carrington Medical Center before becoming the clinical coordinator for the About the Patient program in Bismarck, North Dakota. He currently resides in Rugby, employed at Heart of America Medical Center. He has particular interest in expanding adoption of new treatment strategies in rural communities. With that, Dr. Rue, I'd like you to take it away. Thank you.
Hey, thanks. Appreciate it. Thank you, everybody, for giving me a little bit of time in your day, and hopefully it'll be worthwhile for folks. So yes, talking just very basically about CGM, or continuous glucose monitoring. And really at the top here, I want to probably skip to a couple of slides in here and really say, I don't want to make any bones about it. This really is something that is very, very much a very basic primer. And I know that there's some folks here on the call, the attendees list looks like, who I do think are, definitely some high-level CGM provider users. And, if you're looking for some incredible tips or wisdom, really to really expand what your own expertise is, you might be in the wrong spot. So I just want to say that at the top of the hour in case you need to do some lunch or other things, because we're going to be looking at some real basic items on the report. And it's really just a very, very simple way to think about interpreting CGM data and reports in a consistent manner. So really nothing earth-shaking there, and I just like to be forthright with people here, just so that everybody's on the same page with that. But after that, we'll just kind of keep on rolling. Our objectives are to define some basic CGM metrics, look at one CGM standard report in particular, interpret some data to adjust medication therapy, discuss just a little bit on what some of the comprehensive documentation that mean North Dakota Medicaid billing standards. We'll take that really out of the North Dakota Medicaid Provider Pharmacist Manual, and we'll look at summarize some payable opportunities for people as they currently exist, to our knowledge anyhow. So again, this is really what I talked about. This is certainly very, very basic primer. So if you're a real power user and really confident in what you do, I don't know that I'll be setting your world on fire here today. But to start, CGM is not scary. And honestly, that's one of the things that we see or hear a lot when we talk to pharmacists across the state about CGM and really some of the interest in CGM. There's a lot of confidence, I think, in the fingerstick logbook, but for whatever reason, there can be some trepidation when pharmacists look at some CGM data and comparison, particularly to what fingerstick reports they may see in an EMR, or even just somebody that brings something into the community pharmacy as well. And really, it's really the same sort of data. It's just points of glucose information on a timeline. It's just much better because we are getting a reading generally every 5 minutes. We may get 300 or so readings a day out of a CGM rather than oftentimes 0, 1, 2, 3, or maybe 4 out of a fingerstick type of situation. Some users and providers report that is a very powerful behavior modification tool in a couple of different ways. And that seems to be pretty strong if we're talking about patients or the provider base as well. I think providers really feel that having that knowledge really impacts behavior on a certain group of patients. And really, what I mean by that is a lot of patients will feel pretty empowered about having their CGM data on their phone or app, and they oftentimes, get close to obsessing about it in some ways. And so, some folks have really, really gotten into understanding how their body, exercise, diet choices, medications really impact their data by being able to see it in near real time where they really weren't before if they were just doing a few different finger sticks on a periodic basis. So that's something that I think is probably not discussed enough about how strong that can be for a certain group of patients. Usage is growing rapidly, and I think everybody, certainly in the community side, can attest to that. And part of that is, I think, marketing certainly, but the tool has really just been improved so much, and Medicare had really opened up, I think, what the requirements are for getting billing reimbursement for a lot of CGM devices in the last year, which some are calling unprecedented, and that might be, very, very true with that. So usage is growing, and I don't think that's really going to abate, certainly because we're also seeing the introduction now of some over-the-counter CGM monitors as well, which are not what we're talking about today, but again, just to kind of highlight, I think the utilization is going to be something that we're going to see growing. Sharing the data with the CGM, often with the portals that exist, can be very, very easy. And I've used, primarily, one portal, and it works really, really well. And that, again, I think is that ability to share data from folks, clinic, in the community and the patients, very, very strong, very powerful with CGM compared to a lot of other strategies. And some payers do reimburse pharmacists for that. So we're going to start and pretty much just stay in the orbit here of something called the AGP. This is the ambulatory glucose profile. This is the most basic report really that exists in the CGM world. So we're going to go and break this down a little bit, talk about all the needed elements here, from how much data we have to have, the ranges, and a few other data points as well. This has proven to be kind of a bit of a stumbling block for some pharmacists. And again, I'm not trying to stereotype anybody on the call or anybody off the call. We just know that when people are first introduced to this, sometimes it becomes a little bit of a stumbling block or a little bit of an intimidating thing. And it really, I think, once we start to unpack it, it becomes anything but. And it's really, really a wonderful report. So the AGP itself, it's an internationally recognized standard report. And that's wonderful thing about it is one company to the next, one manufacturer to the next, they're really going to provide you with the AGP data. They may go and have a little different color scheme, maybe a little different organization on the page, but you're looking at the same data package in almost the same sort of way. So it's really a one-page summary of some very, very useful CGM information for folks. So very, very consistent, very, very useful, and that's what we'll be talking about. So let's go and do this unpacking portion. So if we look at the top left here, we'll see some dates in this example. So for CGM really to be useful, we're really looking for 14 days of data in a report or in a go. And we want to have a high percentage of time that the CGM data is active. So in this case, we have 13 days. We're looking for 12 to 14. 14 is really what the preference is. Percentage of time CGM is active here in this example is wonderful. They really didn't miss anything, 99.9%. As we'll get into what some of our goals are, you'll find that 70% is largely what people are looking for. But the glucose ranges and targets, you have a breakdown, a target range, so 70 to 180. That's where we want that number to be greater than 70%. Then we have the hypoglycemia type of, or low blood sugar areas, below 70, and then the very low of below 54. We have the high ranges above 180, and then the very high ranges above 250. Average glucose, very, very simple. What it is just all the glucose values, all those things where we might have 300 readings a day, added them up together and divide by the number of readings. So nothing too strenuous about that calculation. The GMI, it largely it's very, very similar, but not exactly the same to the A1C lab value that you see. And we'll actually talk about that specifically here a little bit later. But what it does essentially is it estimates what your future A1C would be if the data that you see here continues to hold true. So it gives you essentially a calculated A1C in a sense for the data time frame that you're looking at. And glucose variability, this really is, well, I guess it's based on the coefficient of variation. Our target percentage there is under 36%, but the takeaway is the glucose variability is looking at what your excursions actually are. So the lower the number and the variability, the tighter range band that you have for your glucose values coming back. So in this case, the glucose variability being very, very high, we're going to have huge swings in what somebody's glucose actually is, which is certainly not ideal for anybody. And we'll look at that a bit as well here. So the middle section, the heavy line in the middle, that's our median. That's where half of our glucose values above that line are, and half of them are going to be below. We want that line to be as flat as possible because that ends up really showing us that we have a lot of consistency in what our median glucose value actually is. The more peaks and valleys, the mountains and hills that we see, like in this case, we can see that we have somebody who has quite a bit of variability in the glucose that they are giving us. The darker shaded area surrounding that, that's the area that shows us what 50% of our values actually are in that. We like that to be as close to line as possible. Then the lighter shading, that really shows us the 95% of our values there. So if we look at above the 95% line or below the 5% line, that's really just where we're seeing, that's where the 5% outliers, high or low, will be there. So again, to tighten those lines as the color splotches to that median line, that's the most agreeable thing for us to look at. Then bottom, we'll generally see 2 weeks worth of dailies. So they'll plot this, all of the CGM data that will actually be experienced in a given day. They plot that over a 24-hour time frame, and then they'll show us generally that gray band that you see there. That's our target range. The yellows are the excursions high, and then the red are the excursions to the low and very low, which we want to minimize. So I said that we have, kind of a lot of consistency in an AGP, regardless of who the manufacturer is. And again, it's very, very intentional. And so here, just for the sake of illustrating that, here's two different AGP reports. So one on the left, we have our little bit of how better description on what our ranges and targets are. And then we have that nice little bar chart on the right side, only on the AGP on the right-hand side, that's kind of reversed. But then in the middle, we do have the AGP plot and the dailies down below. So largely it's the same information. It is the same information. It's just packaged a little slightly different. And of course, people like to use whatever color scheme that their company likes. And I say, I mean, I guess if you like blue or you like the orange, green, and red, really up to you, but works nicely. So to delve a little bit deeper into the actual range goals, this is really just meant to go and take us through a few things and say these are the goals that people have that you're really going to be displayed on that AGP report. And the disclaimer, whenever we go and talk about anything like that, yes, the targets have to be individualized for people when there's reason for, and there's lots of really wonderful reasons for that. But again, this is something that you'll see. We have the goal ranges here on the AGP really for your standard type 1, type 2 patient. So going through this chart, our goals that you'll see, number of data days for CGM worn, we really want 14 days. Percentage of time active, over 70% of those 14 days. Mean glucose is really, there's not particularly a specific goal for that, but it is something that's calculated. GMI, again, that's largely similar to a calculated estimated A1C. We'll talk about that just a little bit more here coming up soon. Glycemic variability, again, percentage of coefficient of variation. That's something we want below or equal to 36%. The lower we go, the tighter that we end up seeing that median trend line, as well as those color plots, which generally is very, very positive for us. Time above range, very high. High, time in range, time below range, low, and very low. Let's take these really in like one go here. So you'll see we have the time in range, and then we have two levels of high and very high above, and then below, low, and very low. Since I can, go back and forth here, I'm just going to kind of flip through slides. you'll see here on the top right-hand side, you'll see those colors, you'll see those charts, very high, high, target, low, and very low. We are looking for time in range of 70% or better. That's something that gives us actually a really nice GMI or estimated A1C of about 6.7. That's where the derivation comes from. Time above range, we want that to be under 25%, and time above less than 5%. Time below range, under 4%, and time below range, the very low, which is under 54 for glucose, less than 1% certainly, just because of the dangers that hypoglycemia poses to people. The GMI and the A1C. So not going to tell anybody anything that you don't know here, but sometimes we like to be reminded of a few things. But the A1C is really our average blood glucose over about 3 months, and that's what the classic lab test does for us. And GMI is very, very similar, but it's the average expected A1C calculated from at least 14 days of CGM data. So until about 2018 or so, CGM was used to calculate an estimated A1C or an EA1C. This did not always directly match what lab reported A1Cs are, and that caused some confusion and frustration for people. I think you can see if you're looking at what the A1C is, it's a 3-month average essentially, because that's what our blood cell lifespan generally is. And the GMI is at least 14 days. So you can understand how somebody may be looking at the estimated A1C or a GMI over a 14-day period, and it says one thing. Maybe it says 7.5, whereas your A1C might be 8.3, 8.5, and that discrepancy, because of the different time frames, that really causes some issues. Certainly, you can go and extend the interval in your reports and have a GMI over a longer time frame, but a lot of the software does go and give us a 14-day look. So that's where we end up finding those things. GMI has some benefits. It can show the direction that your lab is likely trending over a shorter time frame, which is nice. But to highlight a couple of situations where the GMI will definitely be different than the A1C, think about a short-term illness or a short-term steroid use. So if you're looking at a 14-day period where somebody was acutely ill and maybe they also had some steroid use in there, in that time frame, if that's where you're looking at your GMI, it's probably going to be, very good chance it's significantly different than what your A1C might be over that 3-month period, because it's going to impact your GMI in that 14 days heavily, but it may not impact the A1C as much over that 90-day time frame. So time in range matters, and it matters quite a bit. So we had said that the goal time in range was 70% or better. And if you kind of look at the estimated A1C over here for 70%, that's 6.7 A1C. And roughly every 10% increase in TIR, or time in range, gives us about a 0.8% A1C reduction. So nice little chart, nice way to think. Every 10% that you can go, you're dropping, close to a point of A1C. I guess whatever ranges, whatever roughing it in your mind makes sense to you, that works. But if you, regardless really of what kind of literature or resource you look at, they will go and talk that every 5% increase in TIR is clinically significant. So 10% is a really nice marker, but anything you can do to even get yourself 5% improvement in your time in range, often very, very helpful for the patient. So here we are. We stand at the precipice of the real glory. I'm kidding. There's nothing glorious about this presentation, but our CGM basic approach. Again, the disclaimer is a lot of really wonderful people with very, very deep expertise as providers and interpreters of CGM data. This is something that I think is simple and basic and a good primer, a good place to start. But by all means, there's people who do wonderful work, and they probably have some different thoughts on a few of these things. But as a basic concept, I think this has a lot of merit for people as we go. So let's go and talk about it. There are 4 big questions in this approach. Is there enough data? What is the problem? When or where was the problem, and how do we adjust our treatment plan to make some improvements? So depending on how you look at it, 3 or 4 steps, 3 steps to go and interpret data, and then you make your plan or adjustments as necessary. So I think that's actually pretty nice. Let's look at this beast. So basic approach, number one, is there enough time? Is there enough data? So if you recall, we're looking for 14 days at least of CGM, with at least 70% of that time CGM being worn and reporting data. In this case, you can look down at the dailies, if nothing else, and see, yes, we have all of these wonderful days covered up for us, or at least in progress. So 13 and a half really here for us. So we have the data that we need. What is the problem in the data? That's where the bar chart comes in nicely. We can see what our time in range, 65%, a little bit under our goal of 70%. We can easily and quickly see if we have a hypoglycemia problem, and we really don't, because we're hitting that 1%, and that's really generally meeting our goal. We always will take 0, but that can be difficult for anybody to achieve as well. And then we have the high and very high, where our goal really there is keeping that under 25%, for example. So we can go and see that very, very quickly. Are we in range enough? Are we too high too much? Or are we too low too often? That's really our first spot. We break down the second portion, and then this will show us where is the problem. And so I'm going to just kind of back up a second. The middle portion over the time frame this report is run, so 14 days, this is making those 14 days look as if they're in one day. So it takes 14 days worth of data and it shoves them into what looks like one day. So you can see on the bottom there, 12 a.m., 3 a.m., 6 a.m., 9, 12, and so on, all the way to midnight. This is really what 14 days worth of data looks like, as if it were one day. And so you can go and see where your big excursions were. We can see here just an example, the peach portion. That's where we're having our real high excursions. Seems to come afternoon, and it comes after the 6 p.m. hour all the way through midnight and into the after midnight type hours. That's just one example here. And those are really, again, the data that goes into that is all from those dailies down below. So you can kind of think about it in that fashion. We can, and I guess I'll just rehash since I like to do that. It's the way I learn. Is there enough data? Yes, we have 14 days. We have at least time the CGM active is over 70%. In this case, if you look at the top right, it's 98.7. So we have plenty of data to work with. We can look at where our problems actually are very quickly. We have our time in range is too low. We have a lot of excursions, too much time being spent in the very high, but our time in the low or very low is actually very good. And then we can go and look at the middle section, see where our time problems actually are, where and when did the problem occur. You can see where the highs are occurring. And then if we want to break that down on a day-by-day basis, we can go and do that with the dailies below. And that's really how we're going to go and evaluate our CGM in a very simple, very stepwise manner. And let's go and talk about that a little bit more here. We'll go through a couple more little examples here just to see a few different things. But the next portion, number 4, how do we adjust? So this is a really a wonderful basic chart. I think that can be shared, and it's in the resources references. It's nice. So we have looked at our chart. We want to address hypoglycemia first. If no hypoglycemia, assess our fasting and postprandial hypers. Then we'll look at one change per visit. So in the middle there, glycemic pattern, hypoglycemia, is it happening overnight or when fasting, or is it happening postprandial? We have some very common ways to look at this. This is certainly nothing that's new to anybody here, I think, on the call or the webinar today. Postprandial hypoglycemia, decreased mealtime insulin or sulfonylurea. That's a really excellent way to look at it. That covers, I think, most of the cases that you end up having your CGM patients for. And I say most because that's not true. People in the audience know that there can be some, there's a lot of plenty of exceptions to that rule. But again, we're just talking generalities today. Fasting overnight, look at decreasing the basal or sulfonylurea. Very, very simple, very logical types of things. Hyperglycemia, fasting. So we're looking at how big is the glucose decrease overnight from bedtime to fasting this morning. We can look at adjusting the carbohydrates of the evening meal, add increased mealtime insulin or the agents with both lower the postprandial and fasting glucose. Then if we have a less than, I should say, decrease of 50 overnight from bedtime to fasting. not similar, but looking at add increase in the agent, which lowers the fasting, or increase the agent that lowers the postprandial and fasting. So nothing new or weird, all very logical. And the postprandial, we look at perhaps adjusting your carbohydrates and meal composition, or again, adjusting your medications, I think, in a very rational manner. But that's, again, not at all the focus of this very short basic presentation. But I feel it'd be remiss without at least touching briefly on what some therapy adjustments to think about might be for us. That's what we have today. That's really all we're talking about as far as the adjustment section. Just pretty, really basic things for us to look for. So let's go through 3 separate examples here. If you got the patience for it, and patience for with me. So number 1 here, let's go and step through this just a little bit. We've kind of done this on our first example already, but we'll do it again. So is there enough data? Number 1. Yes, we look at the dailies here. You can easily see you got 13 and a half days. We're doing that. Total CGM time active, 98.7%. Loving that. Looks really good. What is the problem? So for this, the initial problem we want is always going to be our time below range. That's our hypoglycemia being low or very low. The reason is obviously that's the stuff that can hurt or kill somebody. So that is always going to be the first thing we look at, very full stop, what we want to go and see. That's the problem we need to fix if it is present. In this case, the time below range really looks good. We have about a 1%, and that's pretty much our target. We're looking really well. So we can move on to the time in range and the time above range. And that's really where, for this example, I think that most folks would be focusing their energy. The time in range is 65%. We want to go and see that at 70% or better for most patients. And I should circle back too and say the goals do often change a little bit if you are somebody who is more advanced in age or has some very specific risks. We don't talk about like brittle diabetes anymore. It's not something that's really used, but for some folks who, that does resonate with some folks. And so I used it. Our 70% time and range, and then some of our high and low ranges do change a little bit depending on, somebody who's 80 years old probably has a little bit different ranges here than somebody who's 35 years old. And I can circle back to that very specifically here at the end of the presentation if there's any interest in that as well. But sorry for that digression. That wasn't a very smooth portion of talking through this one. But the time and range, too low. Time above our range is too high. So that's something that we're going to be looking at. Number 3, when is the problem? So we can review that and really in the middle section. I think we're seeing quite a few excursions here. If we're looking at the 6 a.m., we're high. The after 12, we're high. And then certainly looking at about 6:30 p.m. or 7. Through the midnight hour, that's where we have our highest excursions. And so that's probably where our focus should be on that. And that's where it would bring us really into the how do we adjust section. And here for these cases, I intentionally, this is not something that goes into all of the, I didn't go and work up somebody that is a very detailed case, because I really wanted just people just to go and get used to using this sort of evaluation tool. But based upon that information, now we'd have the ammunition for us to go and say, well, we understand now what patients' medications are, how they exercise, how they eat. And we're seeing the data coming right back at us. And now we're going to go and make those adjustments. And then move to number 5, document and bill as necessary, and follow up, which for me, my recommendation really is monthly follow-up is generally reasonable. And if we're talking about billing, often the billing frequency allowed for our analysis CGM. So number 2, let's do that again, since it's such a nice time. Is there enough data? Yes, we have at least the 14 in the dailies and at least 70% of our time in sensor being active. You can see it on the top left. We have 14 days and 88%, so we're meeting that. What is the problem? Again, the first thing we are looking at is our lows, because that is the thing that can kill people. So we see a low time of 10% and additionally a very low of 1%. So full stop on this for most people. They'd say this is what we have to target immediately before we worry about any of the very high type of situations. So we've found what our primary problem is in this case. It's the lows. When is the problem? You can go down to, if you look at the middle chart, you can see you're looking for things that are really below that bottom of the green trend line. So you can see the times where we're really seeing that. Lows are mostly in the 2100 to 0300 range. You can also see that represented here in the dailies as well. With the red areas, they seem to happen closer to that midnight hour and then across the midnight into that 0300 type of time range as well, which is certainly not anything unexpected. So based upon that, now we can go and look at our adjustment criteria or adjustment strategies, taking into account what the whole patient picture is. Document a bill as necessary, follow up appropriately. Number 3, last one, again, briefly. Is there enough data? Yes, top left, 14 days, time sensors active 90%, so there's no issue there. What is the problem? We look for our lows. We're looking pretty good there, 2% in the low, which is generally above our cutoff. Really, there is 4% for most people, and nothing really being shown in the very low. So we're in pretty good shape there. Moving on then to the time in range and the time above range. Our target range or time in range, we want that to be 70% or better. We're a little bit low on that, and our high and very high is too high. So that's really where we start to have. If we look at this one here, I want to highlight the glucose variability. Now, most of these examples, the glucose variability is higher than our goal of 36%. In this case, it's 42.8%. So we have quite a few excursions going, in this case, largely high. And that's becomes a bit of an issue, but in other words, we're just having some hard times keeping consistency with this. So in this case, we are kind of all over the place. If you look at our dailies here, you look for all that yellow splattered all over the place. We are all over the place. Our post-breakfast seem to be problems for the very high in particular. And so that gives us a really good insight into what we need to be discussing with the patient as far as what are you doing with your life, exercise, medications, etc., and diet around those times in particular. So that's how we end up closing the loop, or how we end up making this actual analysis hopefully useful for people. So for me, before I go into the next section, I am just going to pause. I'm going to do a little recap here. I know we have, the chat option to go and talk about and discuss this a little bit more. But again, this is not a very difficult stepwise approach. Do we have enough data? What is the problem? So are we talking about, is this an issue of we have a lot of hypoglycemia? Do we have a lot of hyperglycemia? When is that problem actually occurring? And that's where the CGM data becomes incredibly useful, because rather than having scattershot finger sticks, we largely have a ton of data at our fingertips, and that's how we analyze it. Then we go into how do we adjust and make an impact to the patient. So really, it's a 3-step type of analysis situation using the AGP. Gives us great insight. We can obviously delve into more reports, but that's it. That's what I'm talking about, where we are not going into anything that's incredibly detailed, because again, we want to be respectful of folks who are doing that every day, doing a really wonderful job. But just as a primer, I feel that that's a good place for people to start. So that's the end of that portion. Let's talk about documentation and coding just briefly. So note writing, this is not something that's natural to some pharmacists, and that's okay. If you're one of them, that's totally fine. But with CGM, you really need to create a proper note, especially if you're doing any sort of billing for that. This is going to vary a little bit upon practice and payer requirements. We'll talk just a little bit about some of the Medicaid requirements, but I think that there are enough wonderful templates and examples where writing a complete comprehensive note template can be created very well, and we can go and collect the data necessary for that. So some suggested things to think about, very basic features in a note. It's largely, a big chunk of it is the data. It's how long did the patient wear the CGM for this encounter? What is our current treatment plan? Our last most current A1C? key data points from the CGM data download: time in range, above range, below range, your GMI. Discussion a little bit about the patterns that you end up seeing, what the changes to the treatment plan end up being, education provided, referrals, and also it's certainly my recommendation to include a copy of the AGP or other CGM data summary whenever possible or appropriate with that. And there's different software does things a little bit differently with that. Works okay, I think, but always important to have that documented appropriately. So specifically, I know we have some folks from Medicaid present and all, but this is just something taken obviously directly from the provider billing manual for some documentation requirements for the CGM CPTs. That's some name, date of birth, clinical encounter, date of service, credentials. That doesn't really do me a whole lot of good to go and read point by point here. That's very, very similar to, I think, what we saw here. A few extra points. We're talking about some of the assessment of factors affecting the blood glucose levels. There are some 6 enumerations here that are very specific. Treatment plans, follow-up, data follow-up, all very good things. Again, fairly standard type of information, I think, that becomes expected across the board for good CGM interpretation documentation. Documentation and coding. There are 3 primary codes that end up getting looked at when we are talking about CGM. So 95251 at the bottom, the CGM interpretation. That's largely what we're talking about in this presentation. That's where we're looking at interpreting the data of at least 72 hours, no more than 1 time a month. But to go up to the top, there is a kind of an older code, 95249, which was training somebody on CGM, and that it actually kind of varies. Yeah, it varies a little bit because how and what setting people get trained on CGM now has changed a little bit as the technology has changed. So, there is a one time that the patient owns the device, there may be a CPT available for that initial startup and training. Then the 95250, there's something called professional CGM. So at one time, and it still exists, but you may have the opportunity for a patient to go into like a provider office and get a short-term CGM. And then the patient would go wear that and then often come back into the provider office for a data download and be looking at that information, right there. And that sometimes had the purpose of just being a nice training session for the patient as you get them used to the device. Sometimes that was used also as a method to determine if a patient actually is going to qualify for a CGM longer term, but depending upon those results that they received. So again, some of that has changed as insurance coverage and the requirements for CGM has changed. But again, those are the 3 primary CGM codes. 95251 going forward is really what we're looking at in response to, just this very, very basic interpretation overview. Some references, sweet code there, and I have reached the end for me. So happy to go and talk and discuss some things, and that's what I got.
Hi, Jesse. Great presentation. Thank you. That was excellent. I know you downplayed it, that it was very basic but for anybody who hasn't been working in this area, I think it was a really good overview.
Nice. I think too, I should say too, like if there are a lot of wonderful people, if if it becomes that there's like a need for myself or any other folks to go and talk a little bit more specifically about patient cases, more than to describe some of those approaches and some of the adjustment, it's certainly something that can be done in the future without really any real problems. Just really wanted to go and talk about the thought process for evaluating the data as really the foundational piece.
Yes, absolutely. I don't have any questions in the Q&A section right now. Does anybody have any questions that you could either pop in the Q&A or in the chat section? I'll wait just a second here. If we get anything. Okay, nothing as of yet. I am going to just put in the chat function a link where this will be. This is the CAP Center Chronic Disease webpage. This is where all of our presentations and resources will be uploaded, as well as our YouTube page for the CAP Center. We did have one update that you may have received by email. Our webinar with Dr. Diana Isaacs was canceled. It's going to be delayed a few months, and she will be providing us the webinar maybe towards the end of the summer, beginning of the fall. We will have the next session will be available as an on-demand, both pharmacist and pharmacy technician provided CE on social drivers of health. And this is going to be given by Jordan Laduser-Dix, and he's a coordinator at North Dakota Department of Health and Human Resources. So I still don't see any questions in here. So Jesse, Dr. Rue, you must have nailed it all. So thank you for your time today, and thank you for everybody attending. And we really appreciate your support for our session by the CAP Center. If you have any questions at all, please don't hesitate to send an email. Otherwise, everybody have a great day. Thank you.